Our tricyclic antidepressants have been around for a very long time. They work just like an SSRI or an SNRI, and they work just as well. The only major difference is that TCAs have so many more side effects. They typically reserve them for severe depression in those that have not responded to any other treatment. They can be used for migraines, panic disorders, OCD, or even neuropathies. Some of the expected side effects are your mild to severe vision problems, especially with your glaucoma patients. You want to try to avoid these medications because it does increase that intraocular pressure, which will in turn make their glaucoma worse. Dry mouth, dizziness, constipation, nausea, some orthostatic hypotension, and weight gain. In some cases, your patient may actually experience weight loss, so you'll want to monitor a baseline weight for these patients. Some of the adverse side effects with your TCAs are, of course, your cardiac dysrhythmias, heart failure, and seizures. So you want to make sure that you're monitoring those histories of any type of cardiac disorder. Urinary retention. So again, you want to especially assess your patients, your male patients who might have urinary retention or already have urinary retention due to BPH issues. These particular medications can trigger manic episodes, especially with an underlying bipolar disorder or maybe even an undiagnosed bipolar disorder. Delirium in older patients with cognitive impairments. This is where you really have to assess your patient to see if in fact it's delirium or if you are dealing with a patient who may have some type of Alzheimer's diagnosis. Again, with most of the medications that we treat mental disorders with, there's always an increased risk of suicide, especially in our younger patients. So refer back to that assessment before starting a TCA. And again, do not prescribe these to patients with a history of glaucoma. With tricyclic antidepressants, there's a couple of drug interactions, and so most of these we've talked about. So opioids, sedatives, and alcohol, again, all of those increase respiratory depression and hypotension. So if we're taking any of those and a tricyclic, then we're going to see that severe respiratory depression and that major hypotension. So some of the sedatives we just talked about is like your benzodiazepines. Okay, those diazepam, lorazepam, all of those types of sedatives. So we need to avoid those. The others are your MAOIs, your SSRIs, your SNRIs, and St. John's wort. Because remember, all of those affect serotonin or norepinephrine and their uptake. So we have an excess of those floating around. So we don't want to do that. So our antidysrhythmic medications or beta blockers or sodium channel blockers, all of those work in the heart to decrease conduction or increase the conduction. So basically what it's doing is altering the excitability of those cardiac muscles. So with a TCA, they too can prolong that conduction. So we don't want too much of a prolonged QT interval because then we run into some serious cardiac issues. So avoid those because they can prolong that QT interval. Now, serious cardiac issues can occur with marijuana use, okay? And most of the time your patients are going to be upfront with you and they'll tell you more than you really want to know. And so if they're smoking marijuana, they're going to tell you. But the reason for that is cannabis can also cause cardiac arrhythmias. It can cause you to have tachycardia, and adversely, TCAs can also cause tachycardia and hypertension. So we want to avoid those given together. Okay, now tobacco, we want to educate them on smoking or even smokeless tobacco, because tobacco has actually been shown to increase the clearance of TCAs, and it has something to do with inducing or activating a hepatic macro, some type of enzyme that increases the clearance. Okay, you don't have to know the whole cascade, but I just kind of wanted to give you an idea as to why tobacco affects the clearance. So by stopping the use of tobacco, then we reduce that clearance. So therefore, the effects of our tricyclic antidepressant is going to be what it's supposed to be. Okay, so if we have an increased clearance, that means it's not staying in our body long enough to get the full effect of that drug. Okay, so that is your drug interactions with TCAs. And if you have any questions about those, we can talk about them a little bit more. Some nursing responsibilities and teaching we've touched on just a little bit previously, but anytime you give a medication, you're always going to evaluate that response. Remember, that goes back to our nursing process. That's the last step in the nursing process. Did what we give this patient work for them? So are they seeing relief from any of the symptoms that they had previously? Or are we seeing the opposite? Are we seeing adverse effects? Okay, so assessing for those. Now, we always want to assess our patient for any type of suicidal ideations anytime we're taking any type of psych drug. If they are, we need to report that immediately, okay, because that could potentiate a change in medication or a different dose, or they may be experiencing adverse effects. So assessing for those. We can always provide those patients with crisis hotline phone numbers just in case. Most of the time, patients will use them, surprisingly, and some simply refuse. But we can always provide that. Even if we provide it to family members, we've given them some type of assistance when they're not in a facility. Now, with TCAs, if your patient's been taking them for a very long time, we want to taper those drugs. If they're starting a different type of medication, maybe they've gotten used to that drug and they're no longer seeing the same effects or as much relief. So we want to change that drug. We want to taper it because it can cause those withdrawal symptoms, the nausea, the headache, dizziness, or not dizziness, diarrhea, sweating, some of those types of withdrawal symptoms. So do not abruptly stop those. Now, the TCAs do tend to cause some sun sensitivities. So we, again, educate our patients about either limiting their time in the sun or wearing sunblock, okay? Now, TCAs can often also cause dry mouth. So again, we've talked about this before, either suck on a piece of candy, offer some sugarless gum, or just have them, sip some more water, okay, throughout the day. Now, TCAs can cause hypotension, so we want them to change positions slowly. So if you're going from bed to a chair or chair to standing, just make sure that they're aware of that, to do that slowly so they don't end up falling in the floor and creating lots of paperwork for you. Adverse effects, we always want to report those. So if your patient's having any difficulties urinating, blurred vision, or shortness of breath, we always want to report those immediately to the physician so that they can be seen. So that's your nursing responsibilities and your education as far as teaching your patients and families. We always want to include the families. So if you have any questions about the teaching aspect or the responsibilities as the nurse, then send me an email and we'll talk about it. Monoamine oxidase inhibitors we've talked about just a little bit previously, and I don't know if you recall or not, but monoamine oxidase is actually what breaks down some of the neurotransmitters, our dopamine, our serotonin, and epinephrine in the central nervous system. So these can be used to increase serotonin, dopamine, and epinephrine, because we're inhibiting the breakdown of those. So typically this category is used for severe depression, okay? And now, if you recall, the MAOIs are also used in Parkinson's, so that it increases that amount of dopamine that's available. Now, remember, with monoamine oxidase inhibitors, there are those dietary restrictions. Remember, with the tyramine and those types of things. So look back on page 203, 10.5. Remember, we talked about some of the foods that a patient should avoid when they're taking the MAOIs, and that's your aged cheeses, your pepperonis, salamis, things like that. Anything that's high in tyramine, okay, we want to avoid that. Beers, we talked about beers. So yogurts, those are some of the things that are high in tyramine, so we want to avoid those types of foods. So we do have to teach our patients about those diet restrictions. Now, if you remember from a previous lecture when we talked about MAOIs back in Parkinson's disease, tyramine is actually an amino acid that helps regulate blood pressure. So anytime we're talking about an MAOI, you should be thinking about blood pressure regulation in our patients, and then also excessive tyramine in certain foods. So with an MAOI, and we're preventing that breakdown of those neurotransmitters, that serotonin and dopamine, we're hoping to increase our patient's mood and decrease those depressive states. So let's talk a little bit more about the MAOIs. Some expected side effects for our MAOIs are constipation, headache, dizziness, drowsiness, dry mouth, orthostatic hypotension, and some peripheral edema. So remember, monoamine oxidase helps to break down tyramine. So if we're inhibiting that, then we're going to have some blood pressure issues, because tyramine actually helps regulate blood pressure. So keep that in the back of your mind. Now, the adverse effects of MAOIs are liver damage, blood disorders, which your book doesn't really elaborate on specific blood disorders, so I'm going to go with blood pressure, in that with hyponatremia, we have the water sodium balance there. So I'm going to go with hypertension as far as an adverse effect, and thoughts of suicide. Anytime you have a patient who's taken any type of psych drug, most of the time the adverse effects are going to be related to thoughts of suicide, increased depression, those types of things. So another adverse effect of monoamine oxidase is severe hyponatremia. Okay, now that is important. Remember, sodium is extremely important in order for our muscles and nerves to function, and it also helps stabilize our blood pressures. So you can see how severe hyponatremia can be disruptive. So hypertensive crisis, we've talked about this before. It is an adverse effect of, can be an adverse effect of monoamine oxidase inhibitors. Again, this is your extreme blood pressures, stroke level blood pressures, and ultimately kidney and renal failure. So remember, leading back to hypertensive crisis is tyramine and the inhibition of that amino acid, because it does help regulate blood pressure. And so we're inhibiting the very thing that can break that down. So that's where we get into that hypertensive crisis. And that's why we have diet restrictions with this particular class of drugs. So keep that in mind when it comes to the hypertensive crisis, okay? So it always relates back to that amino acid tyramine. Drug interactions with MAOIs, there are a few, and I first want to remind you about foods with tyramine. I know they're not drug interactions, but it does affect MAOIs. So make sure that you're aware of those on page 203. Again, alcoholic beverages, yogurts, sauerkraut, salami, pepperoni, and at least the caffeinated drinks and chocolate. So typically, those are the ones you're going to see as far as testing selections. So make sure that you understand they're high in tyramine and they're affecting blood pressure. So we have to restrict those. So some of the other drugs that we do not want to give when taking an MAOI is going to be your SSRIs, your SNRIs, St. John's wort, because remember St. John's wort increases available serotonin. Any drug that might cause or act as a stimulant, we want to avoid. Okay, epinephrine, venlafaxine, and any other medication that lowers blood pressure, because remember MAOIs can cause hypotension, so we don't want to be taking a blood pressure medication and an MAOI and cause severe hypotension. So think about those. Now, CNS depressants, such as alcohol, opioids, and any type of benzos, we want to use those. We do not want to use those with an MAOI, okay? All of those are CNS depressants. So you're going to see lower blood pressure, so that's going to increase that potential for hypotension or extreme hypotension. Now, as far as insulin and oral hypoglycemics go, they may be at risk for greater hypoglycemic reactions. And the way that happens is MAOIs actually cause an increase in available tyramine, which we all know that tyramine works to regulate blood pressure, but it also increases the availability of norepinephrine, which is a stimulant. Therefore, it increases our metabolism. So lastly, let's talk about mood stabilizers. Mood stabilizers are usually reserved to treat patients with bipolar illness. And of course, we all know that bipolar illness is not curable. These patients are going to be on a long-term or hopefully on a continued medication regimen. Bipolar illness is typically diagnosed by an extreme change in behavior or moods. With that comes difficulties in relationships, their working environment, and sometimes even a huge decline in their everyday living or activities. One challenge to bipolar illness is that patients sometimes can be manic, which they will show signs of rapid speech, flight of ideas, some types of excessive activity where they can't sit still, they'll stay awake for hours, or they feel like they have some superiority complex. They're a king of something or a queen of something. They become very reckless with money and sex. They may have multiple partners. They have no concept of money management. You can review some of those on page 204 in the box 10.6. On the flip side of manic episodes, you sometimes can have patients who are on the opposite end, complete opposite end, where they become extremely depressed. They lose interest in everything around them. They feel sad all the time, and many of them have even considered suicide a number of times. So with those mood changes from one end of the spectrum to the other, you can see how adherence to this medication can be difficult. So when we talk about lithium, the mechanism and how it works is not definitive, but we have used this drug for a very, very long time. So some of the advantages of lithium is that it doesn't have all of those sedating effects. So it doesn't create any type of euphoria. Um, so that can help with adherence to this particular drug. Now, the onset of action is 1 week. If you have a manic patient, it usually takes about a week to get them relieved of their symptoms. Now, 2 to 3 weeks to see that therapeutic effect. Now, if you look on page 205, you guys are going to have to kind of know some of these signs of toxicity. So, lithium does have a very narrow therapeutic range, and what that means is the therapeutic range is very close to toxicity. So if you look, 1.2 is a therapeutic level, whereas toxicity is 1.5 MEQs per liter. So it's very, very, very close. So we have to monitor it closely also. So these patients who start lithium are going to have a lab drawn within the first 4 days of administration of this medication because it has that extreme narrow range. So when you look at the therapeutic levels versus toxicity, when you get to severe toxicity, you're going to start to see organ failure, seizure activity, and possibly death. So some of the early signs of lithium toxicity you guys need to be familiar with. That's your nausea, vomiting, maybe a little drowsiness, muscle weakness, and then some incoordination, some discoordination. So make sure that you know what those are, okay? The severe and then the early signs, because I'm sure your testing is going to ask you about those signs of lithium toxicity and what to monitor for in your patient. Some of the expected side effects for lithium is going to be weight gain, increased thirst, and increased urine output, and dry skin. Now, your patients can also have some slight tremors in their hands when they first start taking lithium. Usually this will go away as they progress in treatment. It should go away. But we still want to assess for that. No matter how long they've been treated or how long they've been taking it, we should monitor for that. But let them know that that is expected. Now, patients who are just beginning treatment have some nausea, vomiting, and diarrhea. Now, if you're into it day 3, then it could just be the beginning of the treatment. But if we've moved past our first lithium level at day 4 and we're still experiencing that nausea and vomiting, then we have to look at lithium toxicity. Remember, it has a very narrow therapeutic range in relation to toxicity. So if we're still experiencing some of that nausea and vomiting after a couple of days, 4 or 5 days, 6 out, then we need to look at that toxicity and maybe adjust the dose. Now, the adverse effects of lithium is hypothyroidism, renal failure, diabetes insipidus, neuroleptic malignant syndrome, and serotonin syndrome. So we'll talk about neuroleptic malignant syndrome and serotonin syndrome, and as we start to look at the drug interactions, you'll notice that diuretics is on the list, and of course, fluid balance is very important. We've talked about previously how fluid balance can affect levels, lab levels of electrolytes. So we want to make sure that we're looking at those electrolytes, especially in patients who are taking diuretics. Lithium has been known to affect the way that sodium flows through the muscle and nerve cells in the body. So we want to make sure that we are not missing something that could cause a cardiac issue in patients who are taking diuretics. We need to be mindful in our drug interactions when we're discussing those with our patients that we encourage them not to increase their salt intake, be cautious about intensive exercising, dehydration, and things that may affect their sodium levels, because as they become fluid depleted, they're at greater risk for toxicity. responsibility as a nurse and in educating our patient is, of course, to always obtain our baseline labs and vital signs. We want to do a CBC. We also want to do that bun and creatinine. Remember, we want to make sure that we have a clearance of lithium that's appropriate. We want to assess our electrolytes, again, of course, looking at that sodium level because of its effects on sodium specifically. Always assess for a history of alcohol use, thyroid issues, cardiac disease, and renal impairment, much of which fall back to the lithium effects on sodium. This, of course, is contraindicated in pregnancy and breastfeeding. We do not want to be giving any babies lithium. Lithium also has that extreme narrow therapeutic range. So patients who are receiving lithium will first, of course, have that first draw within the first 4 days of treatment. Then you can see that they have labs drawn twice weekly during the acute phase, and then 1 to 2 weeks until they're stabilized. Then they can return for labs every 6 to 12 weeks. Also be mindful of teaching your patients that they are not to mix this medication with any other drug. They may mix it with another juice or something of that nature, but not any other drug. And again, avoiding those salt increases and or decreases. We have talked about these two syndromes several times throughout this course, but I put the box numbers and the page numbers for you to refer back to. So please review those and make sure that you're aware of the signs and symptoms of each of these.